I have an idea. What if Larry presented a bit differently?
Oh? What do you mean?
I think it would be a useful exercise to see how our choice of treatment regimen would change if Larry's lab results were a bit different.
Interesting. Let's see what Sarah has in mind.
Let's say that Larry was still on the same medications, and his weight, physical exam, and blood pressure are also the same as they were originally.
There's one thing I've been wondering about, though. Larry's on irbesartan, an angiotensin II receptor blocker. Do they provide any benefit in patients with diabetes?
Yes, irbesartan has shown benefits in patients with diabetic kidney disease in both the IDNT and IRMA trials.
That's good to know. Has anything changed with his labs?
Let's have a look. His renal function is a bit worse this time.
But his ACR is much higher. And he now has 2+ proteinuria on urine dipstick testing.
His LDL-C is not to goal. And his A1C is now 7.6%.
Ah, that A1C level may actually be okay for him, considering that he has significant vascular disease. Do you agree, Sarah?
Yes, based on the ACCORD trial data, an A1C in the mid-7s range would minimize his risks for side effects and hypoglycemia.
Whew, there's a lot of new information to consider. Let's have a look at Larry's revised summary before we move on. All right, here's the summary for this alternative version of Larry's case. So mainly it's his renal function that has changed. He now has proteinuria.
Yes, and his lipids are not ideal.
Huh. This really does require some reconsideration of our optimal treatment regimen.
I see we have 3 orbs for choosing possible additional regimens for Larry with this hypothetical presentation. Again, we plan to continue him on metformin, so we need to choose what other medications would be appropriate for Larry.
And it looks like the first A orb is for selecting the regimen that you would recommend.
Ready? What do you think? We should be cautious about giving Larry a TZD. Patients at risk of heart failure should not use them.
But Larry doesn't have heart failure.
A TZD is not an optimal choice for Larry because he's at risk for heart failure, and a lot of heart failure can remain undiagnosed. Adding a TZD to insulin can increase the risk of heart failure.
Sure, Larry would benefit from the cardiovascular and renal protection that an SGLT2 inhibitor provides.
Yes, indeed. This is a good option for Larry. Data from the CANVAS trial showed that patients with PVD experienced a relatively greater benefit from an SGLT2 inhibitor compared to patients that came in with other qualifying cardiovascular events.
An SGLT2 would likely be enough to get Larry to his A1C goal, since it's lower in this hypothetical situation than what he had in the original presentation. GLP-1RAs are safe to use in patients with renal disease, so they seem like a good option for Larry.
Yes, the LEADER trial results are consistent with previous small studies supporting a reduction in albuminuria with a GLP-1RA. The effect of GLP-1RAs on preservation of eGFR and hard renal endpoints remains equivocal since the studies were rather short. However, there is now satisfactory evidence to demonstrate that treatment with a GLP-1RA is able to reduce albuminuria. Because Larry's albuminuria is significant, using a GLP-1RA is one of our best alternatives. We could consider using a GLP-1RA alone, rather than in addition to his current insulin.
Continuing Larry's basal insulin seems reasonable to me too.
Yes, but we need to consider lowering the dose in order to minimize the risk of hypoglycemia if we add another medication.
Whew, it's not exactly easy to tease out which medications may benefit Larry the most under these hypothetical circumstances.
No, it's not. That's why taking the time to determine our treatment priorities is beneficial. It helps to focus our attention on the most critical needs for our patients.
It's hard to believe we're at the end of the simulation. Let's wrap things up.